I heard about Professor Papillon's work when I was preparing for my final fellowship exam. My professor, Robert Cheeley, bless him, asked me what I want to do, and when I was appointed as a consultant, I said I want to go and see Professor Papillon in Lyon. And he said, why do you want to go and see him? So I said, well, he states that he can actually cure rectal cancer with radiation. And I said, I don't believe that. And Professor Cheeley laughs and he said, yes, I've seen it and I believe it. So I said, I haven't seen it and I don't believe it. So he said, okay, I'll give him a ring. So Papillon was his friend, so he gave him a ring. And Papillon said, oh, send your chap over, we'll teach him and show him what we do and to convince him. And yes, we can cure rectal cancers. So plan was made to go to Lyon. And Professor Cheeley said to me that, Sonny, we don't have a facility in UK at that time, and you must promise me one thing. You go to Lyon, see Professor Papillon, you learn all the technique, but you must bring the technique back into UK and set us the facility up in UK.
It would give me enormous pleasure and pride to cut this ribbon and declare the Papillon Suite well and truly open.
It's a minimally invasive treatment, very low energy, and it's applied to a very high dose, but to a very small volume. So if you imagine an external beam radiation, which is about a liter, applied in 1 minute into a 5 cc volume equivalent, how effective that could be. And that's the success, the secret of the success. And it is targeted directly onto the tumor. It's 20 years since we started treating these patients, and we have treated over 700 patients. This is the world's largest series treated by contact radiation. You've seen this picture. It's our humble beginning when I met Gerard, when our team went to Lyon in 1992. And I have to acknowledge a special tribute to my colleague, Dr. Jim Shaw, who is in the audience today. It is the discussion with him on our trips in one of the Astro meeting. The meeting was in Montecatini, and both Jim and I had to stay in Pisa because all the hotels have run out. So every day on a bus, he and I sit together. We talked about how we could do this treatment because we don't have machines. As Gerard said, we only use these superficial X-ray machines. And I'm pleased that we have the chief executive of the Gilmore. His machines are Therapex, and that's what we started using. And Jim said, we don't have the 50 kV, Sonny, but we will try and get it down to, the lowest we have was 70, but we will work to get it down to 50. And this is a team that I led, myself, Chris Ramo, who's a physicist, and Janet Taylor, who you'll see in a minute, who was a radiographer. And that was Lyon. And that was the machine that they were doing with all these protections. But you don't really need all these protections because the energy was very superficial and the backscatter was minimal. And this just demonstrates, and you've seen this is one of our patients. You can see a cartoon, how these polyps grew. And then after one treatment, the tumor shrank down. And it's just amazing. And you've got to see it to believe it. Because I didn't believe it, I went and I saw it. And I was just amazed. And Kate will always say that it is something that we all learn because we can actually see the tumor just melting away before our eyes. And after the second treatment, the tumor just disappeared completely. And this lady was in remission for 6 years. She was an elderly lady. She slipped and fell and banged her head and had a cerebral hemorrhage and died 6 years later. She always comes to my clinic regularly, and when she didn't turn up, I rang her niece, and niece answered, "Oh, I'm sorry, Dr. Myint, my aunt passed away. She had a fall, and then she had a cerebral hemorrhage. I was sorry to hear that, but this is one of the things that they don't die from this dreaded disease, but from other things that could happen in these age group." You can pick up the responses pretty well by this response. If there is a residual tumor, you can have a technique called TENS, which is a transanal endoscopic surgery, which we've now got the facility in Liverpool and in Wirral. And then if they don't respond well to treatment, then they can go and have the standard surgery. This is Miss O'Donnell, who was a radiographer, who started when we started. This is Janet Taylor, who came to Lyon with us, and I'm sure Jean-Pierre will remember her. And this is our old Therapex machine. We were very grateful for the fundraisers from Birkdale. I'm very pleased that one of the members of the family is here today, and they raised 100,000 with 2 golf tournaments. This is our new machine, which has got a little camera, and this is the advantage over the old Papillon technique, because we can actually see what's happening on the screen as we treat, and we can show the patients what is happening. So it's very satisfying for patients to see what has happened. And we don't really know why some people respond well and others don't. And I'm very grateful to Liverpool University because I have been awarded, and not only that, that has given me the impetus to work with the research unit there to see why some tumors respond well and others don't. And if we know that from the beginning, from the biopsies, we don't need to waste our time doing all this. And then we can just, from the biopsy, we can predict who's going to respond well and who's not going to respond well. And this is one of the projects that we'll be involved in the translational research of these tumors. This is a World Series. Professor Papillon himself has treated over 300 patients. Gerard, this is the old slide, so he treated over 200 patients. Professor Sishis from the United States introduced Papillon facility into the United States, and he's treated over 200 patients. And Bob Marsen is our colleague who still treats patients. And this is our second report in 2007 on the 220 patients. There are side effects, of course, but majority of these are manageable. The side effects is bleeding, which can be controlled, and you can do, and I'm privileged to have a colleague from Liverpool, Dr. O'Toole, who helped me when they have severe bleeding. 5% of our patients needed argon beam. And they have this little ulcer following the treatment, which normally heals after 3 to 6 months. And this is what the scar looks like. And sometimes these little blood vessels can bleed, and patients get really worried. And these are the blood vessels that needs a argon coagulation in about 5% of patients to try and stop the bleeding. We have several challenges because surgery is still the standard of care, and there is a lot of governance issue in trying to change the standard of practice. The number of patients that we treat are small with early rectal cancer, and there are no large randomized trial evidence to support what we do. Regarded by many as unproven treatment, and this is one of the reasons why we didn't get it going for a long time, and Professor Gerard has laid down some plans on how we're going to make this accepted by the community. So far, this has not been approved by NICE, but we hope that when we prove to them that this is a worthy treatment, hopefully we'll get some recognition. Because the gold standard of surgical care for low rectal cancer involves stoma bags, and this is a bag for life. And there are patients who cannot manage these with these bags. And it is important for people who are in power to realize that these stoma bags can cost NHS £8,000 a year. Just one bag a day for each patient. And a lot of people don't actually realize that, including the powers that be. because Papillon treatment that we offered here costs much less than that. It's not the cost that we think about. It's a saving of lives, saving of the complications, and saving of the stoma bags over the years. There's a lot of variation in the stoma formation, and this is the evidence from the survey that was done over this time frame. And some areas in some NHS trusts, about 50% of patients end up with the stoma bags, and other trusts, less than 10% end up. If you are in the far end, the cost to the NHS is incredible. And some patients, when we heard about this, they don't like having a bag and will argue with the surgeons. But it is important to try and appreciate what the patients would like to choose and respect that. And one young patient, and I don't usually have young patients, less than 5% of my patients are less than 50 years. And he came up from London, and he's written a book called Saving My Ass. And there was a lot of controversy in his treatment. And I'm sure Ian will remember this young man. When he came up, his tumor was too big, so we agreed to review the lesion. After the external beam radiation, which he had in London, the tumor virtually disappeared, and we offered him 2 fractions of Papillon. And then we did the TEN surgery, which is a minimally invasive surgery, and there was no tumor left in the scar. And he kept asking me, when am I cured? So I said we have to wait 5 years. And come 5 years, he wrote this book called Saving My Ass. I'm pleased to say he's alive and well, going to Amsterdam, trying to sell these machines now, 10 years on, without any evidence of recurrence. It's difficult for people to think outside the box because our training, the traditions, the guidelines, the protocols, and the governance restrict what we do and what we think. But we must be aware of the advances in technology, the new innovation, and we must create new concept of treatment, because the stage of disease that we treat is totally different from what we used to. Because with the National Bowel Cancer Screening Program, you're going to pick up a lot of malignant polyps, which are very early stage, and we've got to try and treat them as Professor Gerard has shown that the standard practice changing, like mastectomy to a lumpectomy and radiation, this hopefully would be a practice changing at some point. But nowadays there are hundreds and thousands of old folks, as you can see, 1.3 million to 3.3 million in 20 years. So, you know, in this era, we have to try and think of these old folks because the mortality would be very high. The average mortality for 70 plus is about 6.7%. This is a government accepted standard mortality. 80 plus is about 14%. And for 90 plus in his age group, there is 1 in 4 chance of him dying. And if there's a lot of comorbidities, the chance of death is much higher. So we've got to try and think of these elderly patients, which are growing in number in this country, to try and see what we can do to try and minimize the morbidity, all shown in yellow, and all the deaths that are shown, and all the disabilities that could happen to these elderly patients. So in future, what I'm planning to do is, we started doing these international conferences here in this room in 2005, first in Liverpool, then in London and Paris and so on. I didn't choose the venues, it just by mutual choice. And there was a meeting in Nice where we formed this International Contact Radiation Society. We had a meeting in Barcelona last year. This year it's Rome, and then next year it will be in Vienna. All very nice venues, and we have no qualms about that, because we all will meet again in Vienna next year, our team. And this is this very room where these international colleagues meet. This is Bob Marsden, Professor Gerard, Tae Wong from Canada, Philip is there in the background, and so on. So we all meet yearly, either here or abroad, to have these. And this international society elected Jean-Pierre as our first president. He stepped down this year, and I'm now the president of the International Contact Radiation Society, we have a lot of surgeons who are ardent supporter of this. And I was commissioned to do a special issue of the Clinical Oncology, which is our Royal College of Radiologists journal. And that was in 2007. But we do need evidence. But do we need a randomized trial? That's something debatable. For elderly patients, I don't think we need the evidence. But for young fit patients, we do need evidence. And hopefully, with all these trials that we're contemplating, the OPERA trial, the randomized trial, evidence will come out. And hopefully this will be accepted. We've now got a second center in this country, in Hull, for the last 2 years. We've got 2 more centers, one in Nottingham and one in Guildford. And there is potential of nearly 2,000 patients that would have had Papillon. We only treat 100 patients. And with the introduction of National Cancer Screening Program, the number that we're going to diagnose will increase from about 8-10% to 40-50%. And the cost savings that to the NHS will be not in thousands, it will be in millions in 1 year. My journey started in '72 when I became a doctor in Yangon, Myanmar. John Glees has gone through this, came over in '77, got my membership in '79, and I got my fellowship in 2000. I had the first fellowship from Edinburgh College, which was the main college that I got my membership from. That was back in 1990. I stood on the shoulders of many giants, and you all are included, of course, but I would like to mention a few which are very special to me. This is my father, Dr. Bucket, who's a very famous physician in Burma. He was a deputy director of health school, and he won many national awards. And he was a personal physician of General Aung San. Aung San Suu Kyi, you will know, her father was General Aung San, and my father was his personal physician. He died at the age of 96. I don't think I'll see 96 myself, the way I have to work. But one thing he taught me is you can learn a lot from your patients, son. You always listen to them carefully. And then this is true. When he passed away, I was really sad. And I was feeling a bit depressed. And one of my patients said, Dr. Myint, he's not dead. He's within you and helping us. That's a very calming thought. And with that, I will leave my father's contributions. The next person I want to thank is Professor Mamon Singh, who's a professor of surgery. He wants me to be a surgeon, and he tries to train me to be a surgeon. I'm not a surgeon, but I'm doing a lot of implants, I'm doing theater work, and he was very pleased that I was able to do this because he was also a professor of colorectal surgery. And he taught me one message from the Serenity prayer. When I go back to Burma, at that time the military regime was quite harsh and and it's very difficult to do things for them. And he said, I just want to remind you of the Serenity prayer. God, grant me the serenity to accept things that I cannot change. Give me the courage to change the things that I can, and the wisdom to know the difference. So that was a very, very powerful message, and I kept that to my heart until to this day. When I go to Burma, I do things that I can, I keep away from things that I can't, and I try to have the wisdom to know the difference. The next person that I have to thank is Professor Sir Robert Cheeley, late Professor Sir Robert Cheeley, who had a special place in the heart in Myanmar. He was our professor of surgery here, and he became the dean. And he was the president of the Royal College of Surgeons in Edinburgh. And he and I worked very closely. We helped jointly sponsor a lot of postgraduate students in Burma. And Marian Shield, who was going to come today, sadly couldn't make it for personal misfortunes, and she sent all her best wishes and regards. The other person I must thank is in Gilmore. I'm very grateful to you for coming over to open this, because he was a fellow gastroenterologist, and we used to work together. He started in the early 80s, and I was working with the professorial unit in Liverpool. And then Professor Gilmore was the past president of the Royal College of Physicians. He was awarding me for my fellowship when I got the fellowship from the London College. Bob Marsden is one of the colleagues from States. He was riding a bike like that because he had a bike accident, he broke his neck. And again, the determination is something that I learned from him. And then there was a lot of hardship he went through. He was quadriplegic, and he just fought back. And then he's the chair of the RTOG, ardent supporter of our group, and he's one of my international referees for the chair at the University of Liverpool. And of course, I have to thank Professor Gerard, who is a very close colleague and my mentor and my teacher. He was a past president of Astro, past president of ICOM. He was the head of radiotherapy in Lyon and medical director in Nice. It was the view, I always tease him, that he goes for, not because of the medical directorship. It was the view from his office that you could see in the balcony. That was a view to die for. And he was a founder member of ICOM. And again, he was one of the international referee for my professorship. And I have to thank my beloved Eve, whose shoulder I have to stand many a times. And she still did a lot of things. Last night, we were at our place. You'll know that how lovely she was, and she cooked very well. So hopefully we all will be able to have a taste of what she does at some point. Now, this is the patient referral when we were in India. So I had a phone call from a colleague, and he said, "We have a patient for you, Sunny. Could you see him next week?" So I said, "No, I can't." So he said, "What are you doing?" "I'm on the elephant." "So what elephant? Where are you?" So I was in India, and then after our meeting in Tata Memorial Hospital, I was presenting, and John Glees was the chair who invited us to speak. And he said, "Where are you? Which elephants?" I said, "I'm in India. I can't see the patient at the moment. Could you see him next week?" So I said, "Yes, of course I will see him." But we have lots of patients referred in from all over the country, and you'll see the map when we go and visit our center. And over these 20 years, we have several referrals from all over. And although there will be centers springing up, there are potential over 2,000 patients, so we will not be short of referrals. I'm very proud to say that this room was full about 2-3 weeks ago when we have an annual meeting of this Papillon patient support group, which has been supported by Macmillan. And Sue, who is the mother of Mark, it's the patient who wrote the book, won the national award. And she was presented this award in this very room about 2-3 weeks ago, and we're very proud of her contribution to the PAP group. In fact, there are several PAP group members who are in the audience. I'm very grateful to all their support. Changing a standard of care for the patient is a life-changing experience with a stoma. For surgeons and us, the governance, it's a change of standard of care. It's a very fine balance. But there is compelling need for the change because of the bowel cancer screening, increased harm to the elderly patient, very strong patient's voice and choice to avoidance of stoma, which I showed you some evidence of. And although we were told about the informed consent, most of the surgeons around the country don't regard Papillon as part of the treatment, so they don't give this as an option. But if we try to prove the worth of it, they have to start mentioning this and give choice to the patient. I'm grateful for the surgeons who are in the audience who've been with me all this time and giving the choice to these patients. And that is one of the reasons why we get all these increased referrals. This National Health Service will save a lot of money by avoiding the stoma. We can see from the NVOCAP data, the mortality and morbidity that surgery can cause to these patients. And then the patients will be made aware. And the media, I'm grateful for the people who are from the media making these patients aware. And for the change in disease pattern, because we're seeing very early stage disease, we need to try and offer these patients minimally invasive treatment, which is Papillon. We're going to see very early tumors through the National Bowel Screening Program. And we're going to see this center open shortly. And my aim is to establish Clatterbridge Papillon Center as a leading international center for teaching, research, audit, and training. As Sir Ian alluded, we will work closely with Liverpool University and the Liverpool Health Alliance. I will not rest my sword until Papillon contact radiation is accepted as a standard of treatment, not just in this country, but for the whole world. I thank you for your attention.